we'd like to welcome Dr. Majdalany from the Department of Interventional Radiology. He will give us a talk today on postoperative options for lymphatic leaks. Dr. Majdalany did his training, both residency and fellowship, up in the best city in the United States in Boston at Brigham and Women's. And so we're excited for his talk. Dr. Majdalany, thank you very much for joining us.
Thank you for the invitation, Mark, and congratulations, Dr. Saeed. It's pretty awesome stuff. I really have a tremendous passion for lymphatics, and this has been really going on since my training. We used to do a lot of lymphatic intervention in the early days of lymphatic intervention at Brigham and Women's. And in my former place of employment, I was at the University of Michigan in the preceding 5 years. Networked very closely actually with my urologists to really help expand both lymphatic IR, but also their ability to deal with several malignancies and some resections, and really hopefully affect positive outcomes in patients. So without further ado, I just wanted to give you guys an idea of what we can potentially offer. I have no disclosures. I'm always willing to consider some. We'll briefly talk about lymphatic anatomy. I find that when I talk to most medical students on up, they really don't have a good grasp of what's going on. Certainly, you guys work with a lot of rich lymphatic areas and are very, very well versed in it. We'll discuss traumatic chylothorax, not that you guys are operating up there, but really from the standpoint of historically how lymphatic intervention evolved, and that was really the first place that we did lymphatic interventions. And really the stuff that you guys will probably see more often and or be more interested in is what we can currently offer for Chylous Ascites as well as lymphoceles. So the lymphatic anatomy is fairly complex in the sense that we have distinct circulations in the body that create lymphatic fluid, and each area of the lymphatic fluid is actually different in concentration of nutrients as well as cellularity. And unlike blood, where if you draw somebody's blood in their arm versus their leg, or their heart versus their leg, or whichever organ, by and large, it's fairly similar in terms of components. The lymphatics are very different. And we have three different areas that really contribute to overall lymphatic circulation. The liver is the liver and the intestines, each about 40% of the volume of lymphatic fluid is derived from there. The rest of it, the 20%, really comes from the peripheral extremities, whether lower or upper extremities, but more from lower than upper. All of these circulations coalesce in the retroperitoneum at the Cisterna chyli, somewhere around L1 or T12, where in standard anatomy, in about 50% of people, it gives rise to the thoracic duct, which overlies the vertebral bodies and courses up to the left venous angle, somewhere at the junction of the left jugular vein and left subclavian vein, where it then returns the lymphatic fluid to the venous circulation. If we break down each of these circulations, the liver itself, when you look at the portal triad, it allows the portal blood and the hepatic arterial blood to mix, and you have the lymphatics really just around that in the space of Dees. This particular lymphatic fluid is really protein rich. This is a major pathway for albumin return to the venous circulation. And whenever we do cholangiograms, you can actually see hepatic lymphatics. And if you look at these two images, the very first image shows the black arrow, a really small vessel that is paralleling a larger duct, and the white arrow is really showing a bile duct, which gets larger as it gets centrally, whereas the black arrow is showing a lymphatic duct, which really doesn't change in caliber. And as you go centrally, you see the lymphatics may bifurcate, trifurcate, whereas the bile ducts continue to get larger as they eventually go into the small intestine. And just another example of looking at the hepatic lymphatics centrally, and you see a tremendous redundancy of lymphatics. On the other side, you see a wire coming down, that's going through the common bile duct. And when you look at the enteral lymphatics, these are a major path for fat absorption, and really understanding how fat absorption occurs and where those fats go really get into how some people historically have treated different lymphatic leaks. Long-chain fatty acids, when they're ingested, are broken down into chylomicrons, which are then returned through absorbed and returned through lacteals into the thoracic duct. Whereas small and medium chain fatty acids are broken down directly at the level of the villus and microvillus, and then they're able to return back into the portal system. So one of the ways that we treat lymphatic leaks, whether it's chylothorax or Chylous ascites, is to put people on an NPO or small chain or medium chain fatty acid diet to bypass and dry up a leak which may otherwise be occurring at the thoracic duct. So it's really about an idea of knowing where the injury is and understanding the flow patterns to try to dry it out if we can't directly treat it. And finally, soft tissue and extremity lymphatics. This is a fairly extensive system. It's distributed throughout all of soft tissues. And this is fluid that is developed here is really similar to plasma. It's basically an ultrafiltration of what's coming through the capillaries and leaks out, whether part of it is from oncotic pressure with protein balanced, and part of it is from residual forward anterograde flow as it goes to the capillary bed. And this area of the lymphatics is really integral in fluid homeostasis. You think about patients with peripheral lymphedema, as well as immunologic surveillance, because as fluid is returned from the peripheries, they're going to pass through different sets of lymph nodes, which are going to really surveil the lymphatic fluid for any signs of infection, etc. So just some images from a peripheral lymphangiogram, and you see that, again, this kind of classic pattern. The size of the lymphatics is fairly small, irrespective of where you look at it. And this is, like I said, from my fellowship, doing a lymphangiogram starting at the foot. And you see that as we go up into the thigh, it's really not until you get to the groin area that you start to see some major nodal masses and some coalescence of some of these vessels. So lymphatic physiology and flow, just a quick note that, we talked about the thoracic duct, and the thoracic duct is really going to drain the left side of the body, the lower extremities, the GI tract, etc. It's really your major flow channel. You do have a minor flow channel through the right lymphatic duct, which is going to drain the right head and neck, the right upper extremity, the right hemithorax. But all the rest really goes to the thoracic duct. On a day-to-day basis, you're talking about up to 4 liters of flow through the thoracic duct. It's very nutrient rich, whether it's protein, fats, T lymphocytes. So you can see chronic leaks are going to really deplete you from a nutrition standpoint, immunologic standpoint, and it's going to be an issue from a fluid balance standpoint. And when we look at lymphatic vessels, obviously when patients are NPO, you're going to have less flow going through this, and patients may be slightly volume depleted as well. I have a tremendous amount of respect for anytime we do a lymphadenectomy. And this is a lymphangiogram I did in a gentleman. And if you mag it up, you see that every single one of these lymph nodes actually has nearly 20 afferent and efferent small lymphatic channels. So imagine taking out a single lymph node, never mind doing a lymphadenectomy, and how many channels you potentially disrupt that are frankly not visible to us. And you start to see how lymphatic leaks can potentially add up to a recalcitrant problem that is difficult to treat. As the lymphatics go more central, I showed you this picture at the level of the femoral head. These retroperitoneal lymphatics are going to coalesce into larger vessels. And as I said earlier, the 50% of them, when you get to L1, are going to have a cisterna chyli. And that cisterna chyli is bounded by the aorta and azygos, and it's anterior to the spine. So any major retroperitoneal surgeries to the aorta, spinal surgeries, esophageal surgeries, etc., are going to be at higher risk for injury to the thoracic duct, cisterna chyli. Obviously, lymphadenectomies and retroperitoneal exposures and dissections could also create injuries here, because 50% of people, while they have standard anatomy, 50% don't have that standard anatomy. So that risk is certainly there. As the cisterna chyli gives off the thoracic duct and as it ascends, it's somewhere in the neighborhood of 2 to 6 millimeters wide, about 45 centimeters long. It has valves throughout. Frankly, we don't know the distribution or the robustness of these valves. But I will note that there is a tremendous amount of variability. Some people have a single thoracic duct, some have a double, some have a plexiform thoracic duct, etc. So again, particularly in the NPO setting and in an emergent situation, it'd be very easy to have an injury here that would be something that may not even be recognized at the time of surgery. At its termination, wraps around into the left venous angle. Anywhere between the subclavian and left internal jugular vein is the most common termination. And you see a lymphangiogram here showing that communication with the venous system and return of the lymphatic flow to the venous tree. There is, again, a lot of variation here with a single channel, double channels, plexiform channels, etc., and very robust valves at the termination to prevent reflux of venous blood into the lymphatic system. So lymphatic leaks can occur anywhere along the lymphatic tree, and most of the issues are going to happen along the axial skeleton, really from the pelvis to the neck. But lymphatic fluid can accumulate in any of the serous cavities, whether it's the pericardium, the peritoneum, or the pleural space. And the potential etiologies are really are very wide, whether it's congenital issues, inflammatory issues, neoplastic, post-operative, traumatic, etc. And really, the etiology is the single most important factor in determining the outcome for the patient, in addition to how robust the leak is. A higher volume leak is going to be more dangerous for the patient than a low volume leak. Also, a low volume leak is more likely to respond to conservative treatment than would a high volume leak. So those are some generalities that we go with. Just a brief bit of history. Lymphatic IR hasn't been around that long. One of my IR heroes is Konstantin Kopp. He has many things named after him in the world of IR, and he was a major innovator, and he really pioneered the whole field of lymphatic IR over a series of publications in the mid-90s, showing that we could actually get into the thoracic duct, right? That's what we IRs do. We stick a needle and we put wires in things, and to do things that we haven't done before. And he did it first in animals, showing that he could then embolize the thoracic duct. We were at this point already embolizing vessels throughout the body, but never lymphatics. And then did it in humans, followed it up with a prospective trial. And most of the patients were post-esophagectomy who were treated fully for their esophageal cancer, but were succumbing to nutritional and infectious issues post-op, and with quite a bit of morbidity and some mortality. And he was able to effect cure in over 70% of patients with a procedure. So this was a leap forward at a time, and as we continue to improve material science and technology in IR, we've been really been able to expand lymphatic IR beyond chylothorax. The essence of lymphangiography and lymphatic intervention starts with pedal lymphangiography, and this dates the 1950s with Dr. Kinmouth in the UK, showing that he would do a cut down in the feet and use a very tiny needle and do injection and serial radiographs of the lymphatics. And this is how I learned to do it in my training. Thankfully, we don't do it this way anymore. It's painful both for us and for patients, but basically we would inject a methylene blue dye in the interspaces of the toes. We'd then milk the foot until we saw this really tiny little lymphatic. We would cut down on it, skeletonize it, and then cannulate it with a 30 gauge needle and start this injection at 5 cc's per hour, taking serial spot radiographs as we follow the progression of Lepidol. And this would easily take 4 to 7 hours for a whole study as well as a possible intervention. We've made a lot of improvements now, and it's not unusual for me to be able to do a lymphatic case within 1 to 2 hours at most. The resulting images from pedal lymphangiography, aside from it being a challenging and time-consuming invasive study, were actually had really good resolution and gave us a lot of information on flow dynamics, particularly in the retroperitoneal lymphatics. So it was used initially for diagnostics as well as for cancer staging historically before we had advanced cross-sectional and MR imaging. Now it's really more of a troubleshooting thing where we can help fix lymphatic leaks and issues. We don't really use it for cancer staging, of course, right? We have PET-CT and other imaging studies. But Konstantin Kopp used pedal lymphangiography, and then as the lymphatics coalesced in the retroperitoneum and became larger vessels, he would take a needle, scalpel, and aim for that duct directly trans-abdominally. And this is kind of what it looks like as you're doing it. And you're going to take this needle down into this lymphatic duct somewhere in the cisterna chyli or thoracic duct. As your needle approaches, it really displaces the contrast. And you're going to then try to pass a wire that's going to go through this vessel. It's about 2 to 6 millimeters wide and 10 to 15 centimeters deep inside the patient, which is a bit of a challenge, but we can do it with some patience and persistence. And well, when you get in there, that's what it looks like. And then we're able to change out our needle for a variety of catheters or dilators and do our advanced intervention. So the first intervention we treated was chylothorax, originally described in the 1600s. In the early 2000s, estimated 1 in 6,000 admissions. There are a variety of etiologies, non-traumatic and traumatic, that can cause it. With our colleagues in thoracic surgery and particularly esophagectomies probably being the highest risk procedure for that, obviously depending on approach and extensive operator experience can certainly decrease the incidence of this. Classically, what we look for in chylothorax or any chylous leak is the presence of chylomicrons. Oh, that's a send-out lab at a lot of places. So what we really check from a practical standpoint is the triglyceride level. If it's elevated above 110, that has a predictive value that it is likely chylothorax as opposed to a pseudochylothorax or other etiologies. And if it's below 50 in the triglyceride level, it's almost certainly not a chylothorax. If the patient's NPO and the triglyceride level is low, and there's a high clinical suspicion, you can always feed the patient and recheck the level, and almost certainly you'll see it bump up if it's truly a chylothorax. Traditionally, the treatment is a no-fat diet, TPN plus minus IV octreotide to slow down the flow through the leak. Surgical thoracic duct ligation has a mortality of up to 12% and morbidity of up to 38%. So obviously a room for improvement there. And just showing you here a leak into the right, into the right pleural space. The etiologies can be esophagectomy, lung cancer resection, cardiovascular surgery, a host of other things as well. And what we do when we get in, just like we stop any other bleed, stopping lymphatic extravasation, we're going to coil across the area of injury, and we can follow it up with some glue. And the reason we use glue is because the lymphatics are relatively fibrin poor and platelet poor, so you're not able to form a good clot, so we have to really seal it ourselves. So just a nice example there of treating adult chylothorax. This is something that really took off in the early 2000s. There have been multiple papers. The largest paper had 109 patients of only traumatic chylothorax. In my career, I've done several hundred patients to date. With more experience, you have a very high success rate. There was one meta-analysis on this that looked at 407 patients in 9 studies, looking at lymphangiography, thoracic duct embolization, and thoracic duct disruption or maceration, and the thoracic duct embolization technique in a pooled cohort of all etiologies, all of the years dating back from the initial interventions to present in 2018 was about 80%. I can say for traumatic chylothorax right now, having a success rate of 95% plus in less than 2 hours, I would say is pretty typical for what we would expect. We certainly do this in pediatrics as well, which have a wider variety of etiologies, because you have to consider congenital and idiopathic malformation and syndromic issues in addition to all the other things. And this was actually a pretty fascinating kid I took care of, who was 3 months old, who had congenital chylothorax as well as congenital ascites. And you're going to see some things in kids and bizarre patterns that you don't see in adults. And this was an example of thoracic duct atresia, which is unfortunately incompatible with life. But they basically had no retroperitoneal lymphatics in this meandering vessel somewhere in the mesentery that was draining their whole lymphatic system, and really a terrible condition. You know, we try to do lymphovenous bypasses and stent reconstruction in these cases, and unfortunately, the success is still needs to be improved. But there are lots of smaller series in the pediatric literature as well, and in experienced hands, you can really approach the same same outcomes in kiddies. The smallest child I've done is about 500 grams, and we were successful in treating them and their chylothorax. You know, challenging, but with experience, you can do quite well. So switching on to the stuff that you guys are probably going to be more interested in, we'll talk about Chylous ascites, and like chylothorax was initially described in the 1600s as well. The initial description was a 2-year-old who had tuberculous Chylous ascites. In the 1970s, it was estimated that it's about 1 in 12,000 admissions, hospital admissions, are for Chylous ascites. I suspect that that's even higher now. I went back through all of the prior papers looking at incidence of Chylous ascites back to the 1930s. And from different parts of the country, from New Orleans, San Francisco, Boston, etc. And created this graph just kind of showing that, truly the incidence was increasing. It's somewhere estimated in the 100 to 250,000 range, somewhere in the 1930s. And by the 1980s at MGH, the incidence was about 1 in 11,500, give or take. As surgical techniques have improved and we're able to treat more cancer patients with more advanced retroperitoneal exposures, dissections, et cetera, in addition to mesenteric surgeries, I expect that this incidence is probably higher. But nothing to show it in the literature, just a hunch. And given how often we see it in treatment-wise, probably true. Symptoms are going to be weight gain, abdominal fullness, dyspnea, leakage of milky fluid from any of your drains or the incisions, etc. The fluid studies are going to be similar to chylothorax, and really what we want is that triglyceride level is really the key for any chylous leak. So it's not usual for the fluid to be alkaline, turbid, opaque. It looks like buttermilk. There's just a picture of a patient I recently treated here. And can be traumatic and non-traumatic causes. Certainly, hepatic issues can also cause ascites, and in a minority of cirrhotic patients, some of them will have chylous ascites. But really, we're just focusing on the traumatic etiologies here. If the etiology is malignant and somebody has chylous ascites, it really portends a very bad prognosis, so nearly 90% mortality at 1 year. But if it's non-malignant, you have about a 40% mortality at 1 year, depending on what's causing it. And if it's traumatic, you're going to probably have the best outcome of any of these patients. One quick shout out that I'll give to a major advancement that we have in imaging lymphatics is a dynamic MRI lymphangiography. This came about just in the last few years, where basically we can, instead of injecting gadolinium intravenously, we actually inject it lymphatically. Similar to how I do other lymphatic studies. And this is going to give you both dynamic flow information as well as that excellent temporal and spatial resolution that we're used to in MR. So very useful for diagnosis as well as procedure planning. And I use it for non-traumatic leaks to kind of help whittle down the differential diagnosis, any kind of complicated lymphatic leak if I don't know what caused the injury, and to diagnose lymphatic flow disorders. Just to show you, this is a pediatric patient that was born with congenital chylous ascites, doing the MR lymphangiogram, and you see that beautiful thoracic duct draining all the way to the left venous angle. And this is an example of a normal study. We did no intervention. And as this child grew and matured, the lymphatics also grew and matured, and the ascites resolved. Contradistinction, here's another child, similar presentation, congenital chylous ascites. You do this injection, and it's just a robust leak into the peritoneum. Obviously, this child needs to be intervened on to help resolve this issue. We did a combination of lymphatic procedures as well as operative intervention, and we're able to treat what was ended up being an extensive lymphatic malformation in the retroperitoneum for this child. So I'm showing some examples of chylous ascites and lymphangiography, and these were actually all urology referrals when I was either here or at the University of Michigan. This first one is a 45-year-old gentleman who had a 7-centimeter RCC incidentally found on a CT for abdominal pain, and cured of his cancer. Eventually came to the University of Michigan after 6 months of being on a TPN and NPO diet, had lost 40, 50 pounds. And you see the typical retroperitoneal lymphatics, and just below the surgical clips, he has this robust leak going up to the left upper quadrant. And this is really what it looked like at the end, just to show you how much was pouring out. Now, I only inject about 20 cc's of lymphatic dye in there, and you see it really pulling all around his spleen. So you can see that this gentleman had a very robust leak. I was able to get into these particular areas of injury and embolize them all. And within a week, he had his drains out, was doing great. And I still get an annual Christmas card. He's put his weight back on, is running a small business. He's a physical therapist. And really, these high volume leaks, if untreated with a procedure, it's very unusual for them to stop on their own. Another example, this was a younger gentleman who had testicular cancer, and doing lymphangiogram looks really beautiful. You see the interspersed lymph nodes with lymphatic vessels here going up to L4, L5. And you see all the clips. Surgically, we had extensive retroperitoneal dissection of what was a lot of malignant masses. And you see here, what really started as lymph nodes really becomes an amorphous leak going on both sides. And just doing some additional images, just showing you how this continues to leak out into the abdomen, and just showing it on a CT intraprocedurally. And we were able to fix these leaks as well with focal embolizations. Finally, a 3-year-old child here who had a Wilms tumor resection with a high volume chylous leak in the bed, and doing the lymphangiography in this case. And just to kind of show you what it looks like as it moves up, and you see this typical pattern of the fluid moving up and then pooling into the area of the leak. This is what it looks like on a CT, and you see a big bright light bulb where his leak was. And what I did in this case is I injected a very dilute glue through the lymph nodes to get it to flow up to the area where the leak was, and we were able to successfully treat him in 2 sessions, 3 days apart, and what was a 600 cc a day leak went away right after the 2nd session. So as I went back through all of the traumatic chylous ascites literature and lymphatic IR, I had led a multi-institution study when I was at the University of Michigan, and looked at 2 other large studies that were there, one from Korea and one from UPenn, and all other reports that have been published. In total, as of last year, there were 19 manuscripts and only 96 patients described. So it's not like this is something that is routinely discussed or known about. And it's really the impetus of why I want to talk to groups such as yours. And in those 96 patients, whether or not a leak was visualized was only reported in 82 of them. So in 60 of those 82, a leak was visualized during lymphangiography. When a leak was visualized and they did lymphangiography alone, no intention to do an advanced procedure, purely a diagnostic procedure, the lymphangiography with no additional intervention was able to seal the leak in 70% of the patients. And that's because the dye that we use for lymphangiography is an oil-based, it's ethiodized oil. And as it leaks out, it can saponify the fat and create a granulomatous reaction and seal small leaks. So we know that if we do nothing else, aside from the lymphangiography, we're going to affect a fairly high rate of cure here for the lymphatic leak. When you look at the embolotherapy, and obviously anytime you're looking at a small number of patients, there's going to be preponderance of positive outcome reporting. There's going to be that bias. But when we do embolotherapy, the clinical success rate can also be increased. So it's not unusual for me to do a lymphangiogram. If I see a small leak, I may just leave it be unless it's been there for some time. If I need to get more aggressive, or if I can embolize it without putting the patient in additional risk, I will do that. So there's probably a fractional increase in efficacy if we embolize the leak directly, but I'm not sure that we have to embolize all of the leaks. Sometimes just doing the lymphangiogram is obviously going to help patients and really minimize any potential risk for complication. I can do the lymphangiogram actually with 25 gauge or smaller needles, frankly, with lidocaine or nothing. So patients who have very little reserve can still be intervened on and helped. And so I gauge all those things when I look at patients to see, how aggressive do we need to be, and how soon do we need to do it, how much of the reserve has been diminished. If we pivot over to lymphoceles, compared to chylothorax and chylous ascites, which were both described in the 1600s, this is more of a modern medical issue. This was first reported in the 1950s. And functionally what it is lymphatic leak that is encased in some type of fibrotic tissue, right? Basically like a lymphatic pseudoaneurysm, for lack of a better description. But basically some type of trauma or surgeries happen near lymphatic networks, whether it's from pelvic lymphadenectomy, retroperitoneal lymphadenectomy, bypass grafting, ECMO cannulation. It's been described for all sorts of things. Again, technique, approach, operator experience, all are going to dictate how often this may occur, as well as how extensive the surgery is. Uncommonly is it symptomatic. So more often than not, it doesn't need to be treated. But, and I show you this case here, there's a very large lymphocele in the center displacing the bladder all the way to the left. Obviously, this patient's probably having urinary issues, frequency, potentially even incontinence, as well as probably pelvic heaviness. And this patient probably needs an intervention. So when we drain the patient, it actually doesn't look like chylous fluid. It actually looks similar to urine. We need to make sure that you're draining the lymphocele aside and not the bladder accidentally. but they can, basically can have that straw-colored appearance. And what I send this fluid for isn't triglyceride level, right? Because this hasn't reached um, the mesenteric and hepatic lymphatics where more of the nutrients are going in. This fluid should be high in lymphocytes. So what I send this for is a cell count. If you see a preponderance of lymphocytes, it is likely lymphocele. If you see neutrophils, it could be a superinfected lymphocele. And I send it for a creatinine level to make sure that it's not urine. But the appearance of a lymphocele itself is usually a well-defined cyst appearing that's uniformly low density and it's non-enhancing. IR treatment for this has actually been described for several more decades because we start with drainage and plus minus sclerotherapy. But more recently, we've actually started adopting lymphangiography and embolization for this as well, with a higher success rate for the recalcitrant lymphoceles. And just to show you an example, this is that same patient with this large lymphocele that's displacing the bladder. There's all sorts of percutaneous sclerotherapy that we can do, all sorts of substances you can put in. My choice is ethanol. I find that to have the highest efficacy. But we place our drain in. That's what it looks like, and you see the lymphocele next to the bladder in this case, and that's what it looks like on a radiograph. I inject the sclerosant. It gives you that starry sky appearance. And then after allowing it to dwell, I'm going to aspirate it all out and recheck it. And you see now that things are really back closer to midline. I make sure that there's no output for about a week, and then I can pull the drain once the patient's symptoms have also resolved. This was a review that was published in 2005, and by then you see how many other papers have been published on this. So this is something that's been going on for some time. There are many more larger retrospective descriptions as well in manuscripts, and this is something that we do routinely and with high success rate. We can certainly treat difficult areas. There's a left perirenal post lymph node dissection with that lymphocele really having a lot of pressure, and us being able to get in to these tight spaces, drain it, and do sclerotherapy, and we resolved it in this patient's case as well. We can do lymphangiography if a patient, if we don't want to muck around in potentially an inflamed, infected area. This was a patient who had complete aortic reconstruction from the aortic root to the left common femoral artery. So extensive reimplantations, grafting, etc. We really didn't want to go in there with anything to introduce any potential risk of infection. So I proposed to my colleagues, why don't we just do a lymphangiogram? Let's see what we see. I'm going to be below any of the surgical margins. It's going to be a small needle. You have to put him asleep. And here's the lymphangiogram. And if you just pay attention to that area, you see it starting to take on this amorphous type of look. And now you start to see that leak. And there's the leak. Doing just the lymphangiogram alone stopped the leak. It's a small leak, but it was causing him symptoms, and he had a drain. We were able to remove it and didn't have to do anything mucking around in the belly to put him at risk of infection. So the approach can really be tailored to what the patient needs. And I showed you the example of the child with Wilms tumor where he did nodal glue embolization, some other descriptions for it for pelvic lymphoceles, lymphoria as well. And just to show you a patient who had a low drain here who had persistent output from this drain, and I'm injecting, and you see the leak going directly to the drain. I'm going to switch that out to glue. I don't have a big margin here to treat it with Lipido or other margins with other things. If it's a ruptured lymphocele or if it's such a small cavity, you can't really do sclerotherapy. So these particularly useful technique. Another example here with a drain in the pelvis, and you see the leakage. Yet another example showing you the amorphous leakage right around the drain. Not a big margin here to do embolizations or sclerotherapy directly. So we're just going to do embolization through the node. And we can certainly do on multiple drains of the same patient, prostatectomy, radical lymphadenectomy. And you see this almost beading appearance near the drains. That's because the dye that we use, again, is oil-based, and it's that oil on water appearance. You found the leak when you see that. And to give you an idea, this is how many leaks this gentleman had, and we treated all of them. We were able to get rid of all of his drains. So this is my general algorithm that I talk to people about when I approach lymphatic leaks. depending on what was done and where the leakage is. If it's a chylothorax or Chylous ascites, you're going to send it for triglyceride level. If it's a lymphocele, you're going to send it for cell count. If the triglyceride level is over 110 or the lymphocyte predominance in the cell count, we're going to start treating it with following the drain outputs, dietary modification plus minus IV octreotide. If the output is high, we're going to be more aggressive with intervention. If the output is lower, we can follow it for a week or two, but if it doesn't resolve after 2 weeks, we're going to be more aggressive. Otherwise, if it resolves, you're going to follow it to resolution. If it's a symptomatic lymphocele, we're going to start with drainage and sclerotherapy plus minus lymphangiography and embolization if a leak is visualized, and then we'll follow to resolution and repeat treatment if necessary. So I hope I've convinced you guys that lymphatic interventions is both exciting and growing. We have a high success rate, particularly in experienced hands. The etiology is really the key. Whenever we're looking at post-op leaks, you know, obviously we can look at the op report and get an idea of where the injury may be as we discuss it with our referrers. Chylous ascites really have emerging and very promising experience in treating post-op leaks. Lymphoceles has been around a lot longer with many approaches and high success rate. So I'm happy to answer any questions you guys have. I'm happy to field any questions by email, and I want to thank you guys again for the invitation to come and speak to you.
Thank you very much, Dr. Majdalany. Does anyone have any questions?
Bill, this is Ken Ogan at Emory. I got a question. So when you treat these lymphatic leaks that are higher up towards the thoracic duct, what are the downsides? I mean, I assume people develop collaterals, but could that lead to lower extremity lymphedema, or like what do you counsel the patients for in terms of the potential risks?
That's a really great question. The thoracic duct, when we embolize it, there's been one longitudinal paper that looked at patients post-embolization at 5 to 7 years. And this was done with the traditional approach of pedal lymphangiography and then direct abdominal access and embolization. In that paper, 12% of patients had some degree of chronic diarrhea, and about 8% had lower extremity swelling. When we've now changed the approach from pedal lymphangiography to a nodal approach, so we don't work from the foot, but rather from the inguinal area, we don't have a follow-up data on that, but we presume it's lower. The risk of additional issues, the reason that it collateralizes so well is that there are lymphovenous channels at multiple levels, whether it's the azygos, hemiazygos, and other collaterals that typically form. I'm actively following about 200 patients right now. I think the embolization approach that we used before was a more aggressive embolization than what we do now. We try not to embolize as low as we used to, and I think that's probably resolved several of the issues. There are ongoing studies where I'm following patients where instead of doing embolization, what I've been doing to repair injuries is doing stent grafting to try to maintain anterograde lymphatic flow through the lymphatics. While that works to treat the leak, unfortunately, this is unpublished data, the stents don't seem to stay patent irrespective of what we do for them, probably due to the slow flow through the overall lymphatic system.
Thanks.
Bill, that was a great talk. This is Viraj Master. I have a tremendous amount of lymphatic leaks in my practice from large renal cancers. Prevention is better than cure in many senses. Do you ever do pre-operative lymphoscintigraphy or lymphangiography any longer? I know you referenced it historically, and is there an opportunity, especially for large, bulky lymph node positive left-sided cancers, to stop things before surgery? Thank you.
Thank you, Dr. Master. That's a great question. I would suggest for us to probably not move in the direction of doing the preoperative embolization because, you know, I would rather leave it to be a kind of a virgin lymphatic tree and not have to deal with the potential collaterals, because as it starts to collateralize, it can become very challenging. you know, obviously there's a subset of patients that won't have any issue post-op, and obviously we wouldn't have to do any procedures for them. But overall, our ability to treat these is very good. This is something that's been my passion probably for about 15 years of my career, having done hundreds of patients a year. Now this is at my third university where I've started a lymphatic intervention program. And overall, you know, our success rate has been very high. For traumatic leaks, I do think that greater than 95% success rate in 1 to 2 sessions is something that I can very confidently give you.
Thank you. We have a couple of minutes. I was going to say, again, for the residents, prevention is better than cure. I noticed that that picture that Dr. Majdalany showed for that left-sided leak after nephrectomy, there was a large amount of clips near the renal hilum, but there was a smaller or absent amount of clips lower down. I bet you this patient had a lymphatic channel that was feeding a large lymph node that just wasn't clipped or controlled in some way. I know that because I have made those mistakes before. So again, for large left-sided node positive tumors, I'd consider placing some clips down low as well. Thank you.